we'll start.
Yep, just 1 minute.
Sure. Cosa? Una ventina, devo parlare un quarto, parlare un quarto d'ora. Come faccio a accettare se non lo vedo?
Okay, and we are now also live on YouTube. So now is probably a good time to start. So, buongiorno everybody, good evening, good morning, good afternoon, buon pomeriggio, depending wherever you're joining from across Europe and the USA. I would say a very warm welcome back to Journal Club. We are delighted, all of us on the Journal Club committee, to welcome you back to restart our Journal Club. We've been hard at work over the summer, listening to your feedback, listening to your comments on ways to improve, your suggestions, and hopefully we've taken on a lot of the feedback and really tried to deliver in the next phase a bigger and a better Journal Club for all of you. Nevertheless, it remains to say that this is your Journal Club. We very much feel this is something by the fellows and for the fellows. So indeed, if you have any comments, suggestions, or you want to join us and take part, we're an open door for all fellows and you're all invited to join us. So to kickstart, it's a very big pleasure for all of us to welcome Luca Naifovino from Padua, who will be presenting the ROLEX study, which was published in your intervention. And as our expert, a warm welcome back to Professor Giuseppe Tarantini, also from Padua in Italy. So we have really an all-star team to restart the Journal Club, and so really looking forward to your discussions. Luca, I'll hand over to you shortly for the presentation, then we'll move into the expert discussions. And if you have any questions, please type them in the chat and we will moderate them at the end of the presentation. Okay, over to you, Luca.
Okay, thank you very much for the kind invitation. It's a pleasure for me on behalf of the Padua team and the ROLEX investigators to share with you the results of this study, which was recently published in your intervention. So, as you might know, the acronym of ROLEX, so ROLEX stands for Revascularization of Left Main with the Resolute Onyx, and it's a prospective international multi-center study in which we investigated the outcomes of left main PCI with a new generation Zatarolid saluting stent, indeed the Onyx stent by Medtronic. So just a couple of slides. Well, these are our potential conflict of interest very quickly. So just a couple of slides of background. As you all know, PCI is a guideline recommended option for the treatment of left main coronary artery disease. And indeed, the latest CTS guidelines, together with ESC guidelines, give a class 1 level recommendation A, recommendation for level of readiness A, recommendation for PCI in patients with a low syntax score, a 2A recommendation for patients with intermediate anatomic complexity, while above 32 of syntax score, of course, we know that CABG is considered superior, and that's why if CABG is an option, PCI is class 3. Pretty similar are the indications in the very recently updated guidelines of the American Heart Association. And although, of course, CABG remains a class 1 indication, we have a class 2A indications for PCI in patients for which PCI can provide equivalent revascularization to that possible with CABG. So just to give you a very quick update on the latest evidence on the topic, these are slides which are courtesy of Gregson, which basically refer to a patient-level meta-analysis published in Lancet last year of these 4 trials that you see. It's Syntax, Pre-Combat, Excel, and Nobel. And as you can see, taken all together, up to 5 years, when we pull the results of these 4 trials, there is no difference in all-cause mortality. And if we analyze the results of the patients for which we actually have up to 10 years of follow-up, namely the one included in the Syntax and in the Pre-Combat trial, we see, again, no difference in mortality, all-cause mortality at 10 years. We all know, actually, nevertheless, that there is a difference. Indeed, the CABG has a clear advantage in patients with extremely high anatomical complexity. We know by guidelines is above 32 of syntax score, but below 32 of syntax score, PCI is at least equivalent, if not even superior in some cases, to CABG. And with this in mind, we decided to study the performance of this new generation stent for left main PCI when we conceived the study about 4 or 5 years ago. And another important point is that all the evidence that I just shared with you comes from studies that did not use dedicated DES for the left main, because these DES did not have a large vessel dedicated platform and indeed had just limited expansion capabilities. And the Resolute Onyx stent was actually the first one among the major manufacturers to come out with extra large vessel designs, meaning with 4.5 to 5 millimeters with a max expansion limit of 6 millimeter. And this seemed very appealing, to perform PCI in the left main. Very quickly, a couple of information about the stent. As I just showed you, this stent is available in extra large vessel size in pretty much all the different lengths. It's a Zatorolimus elusing stent, and it's pre-mounted cobalt alloy and platinum iridium alloy based stent with a strut thickness that it's around 80 micron for the normal sizes and 91 micron for the extra large vessel sizes. And we know it's different. It's very difficult to compare radial strength among the different manufacturers, because they all give you different types of measurements in this field. But what we can say is that it has a pretty good radial strength even when it comes in the large vessel platforms. And all this together, also together with the large possible side branch cell size that can be achieved with this type of stents, all these characteristics make this stent appealing for the use in the left main. Again, this is a stent designed to be deployed also at, and overexpanded up to 6 millimeters. And if we compare this with other benchmark in the industry, we can achieve this type of measures without, peeling off the structure of the stent, because the stent is actually the design. We don't have to, overstretch the device. So as we said, about 5 years ago, we conceived the study, which was conceived as a prospective international multi-center single-arm registry of 450 patients with a protected left main coronary disease, which were enrolled at 25 Italian and Portuguese sites. Of course, as per guidelines, this patient needed to have a left main disease with a low or intermediate anatomical complexity, so syntax score below 33, and had to be evaluated by the R team. This number, 450 patients, is not by chance. We had our statistician working on the sample size calculation based on the expected target lesion failure rates of previous studies. And we also pre-specified three sub-analyses, namely one about, on the patients that underwent intravascular imaging, another one on patients with isolated left main disease with or without the involvement of the proximal LAD or left circumflex. And then we also tried to, analyze in a pre-specified sub-analysis what were the outcomes when we used this particular XL, so extra large stent size. Very important, this study had a core lab evaluation of all angiographic exams, both at index procedure and at follow-up, in case the patient had a subsequent coronary angiography in case of an event, most of the times. And all the events were adjudicated by an independent clinical event committee, which did not involve the investigators, of course. So again, the aim of the present study was indeed to assess the safety and efficacies of PCI of the left main with this particular latest generation stent. The inclusion criteria were, of course, the presence of a significant, severe left main stenosis, according to a diameter stenosis of more than 70%, and particularly in intermediate lesions, the use of IVUS or coronary physiology was advisable, to confirm the severity of the stenosis. Patient could be enrolled if they were acute or stable, no problem. And of course, since the the first design of the study was with a 2-year of follow-up. The patient had to comply, had to have the ability to comply with the 2 years of follow-up. The main exclusion criteria were, of course, prior left main PCI or CABG. The patients were excluded if they have severe CKD or cardiogenic shock or severe left ventricular dysfunction, or if they had a perceived extreme high risk of bleeding, which would configure it would lead them to the inability to tolerate DAPT for at least 1 year. Of course, a patient with high anatomical complexity, so syntax score more than 32, were excluded per guidelines. The study endpoints, so the primary endpoint was a composite, was a target lesion failure composite at 1 year, which means cardiac death or target vessel myocardial infarction, or ischemia-driven target lesion revascularization. The secondary endpoints were basically all the single-digit endpoints, including also stent thrombosis, periprocedural MI, and stroke. So let's go quickly to the results. And as you can see, we enrolled patients around 32 years of age with diabetes in 1/3 of the cases, mostly patients with conserved left ventricular ejection fraction, stable patients in about half of the cases, but we also had 53% of acute coronary syndromes. And 7% of patients had an indication to oral anticoagulation. As you can see from the geographic standpoint, mean syntax score of around 25 with low anatomical complexity in about 1/3 of the patients. Involvement of the distal left main in 78% with a true bifurcation in about 20% of the cases. As you can see, severe calcification in 12% of the patients. If we move to the procedural characteristics, you can clearly see from the beginning that now we can, at least in Italy, we perform PCI in the left main through the radial approach in more than 2/3 of the time. Very important, about 200 patients, so 45% of the study population underwent intravascular imaging, and we'll go back to this aspect in a minute. Rotational atherectomy in a minority of cases, and as you can see, most of the times quite a complete vascularization with a mechanical support, most of the time Impella, but also some EAVP, in about 13% of the patients. Talking about the stent strategy, so the initial strategy of the operators was a provisional approach in about 80% of the patient, and the final treatment was indeed one stent in 77% of the patient, and in the rest of the patients, so 23%, a two-stent technique was applied with the T or TAP stenting and DK crush as the preferred two-stent strategy in our studies. As you can see, about 70% of the patients received an extra large vessel platform, and as suggested but not mandated per protocol, and by current practice of a good PCI in the left main, POT performed in almost 90% of the cases, with 93% of kissing balloon in case of two-stent implantation. This is a very important slide, of course, the 1-year outcomes. We had a follow-up of 100% of the patients. As I remind you, we had a core lab and the clinical event committee evaluation of all the events, and the target lesion failure, so the primary endpoint, was reached by 5.1% of the patients, 12 cardiac death, 12 target vessel MI, and 2% of target lesion ischemia-driven target lesion revascularization. Among the secondary endpoint, I'd like to point out the reasonably low rates of stent thrombosis, just 1.1%. So 5 patients experienced a stent thrombosis, 2 indeed after premature discontinuation, 1 for bleeding and another 1 for, if I remember well, non-urgent, non-cardiac surgery. So if we move to the pre-specified sub-analysis, what we saw is that after adjusting again, this was not a randomized study, of course, so we have to take into account possible confounders, but we did adjust this analysis for age, gender, diabetes, and intravascular imaging, and the clinical presentation, and also of different centers and operators. And we did not, after this adjustment, we did not find a difference between patients with isolated left main with or without involvement of the proximal LAD or left circumflex as compared to patients with more extent of disease. Nevertheless, this was of course underpowered. It's interesting to highlight the fact that patients who actually really had just an isolated left main disease, this was just the 10% of our population, we just had one event, which was an ischemia-driven TLR, no stent thrombosis, and no cardiac death. So again, PCI in the setting of isolated left main disease seems to be a good, extremely good strategy. Another sub-analysis, which was underpowered in the end because we just had 78 patients receiving an extra large vessel platform. Again, no difference in this subset of patients as compared to the patients receiving other sizes of the ES. But probably one of the most important slides of my presentation and the result of the study is this one, which is the one about intravascular imaging. And as you can see, angio-guided PCI as compared to IVUS or OCT-guided PCI after adjustment of all possible confounders was actually associated with a significantly higher incidence of the primary endpoint and also of all single-digit secondary endpoints. As you can see, there was a difference in mortality, cardiovascular mortality, a significant difference also in stent thrombosis and also in all different endpoints. And importantly, this is a something that it's not in the paper, but it's interesting. It's food for thought, as we used to say. It's that if we perform a QCA and we see that basically both IVUS, the intravascular imaging group, and the angio-guided group had the similar, measures of the target vessel when we perform QCA. Actually, in the end, what we did when we actually performed intravascular imaging was upsize our stent in more than half of the cases, meaning that when QCA was comparable, the use of IVUS probably led the made the operator more confident in the use of a larger stent platform. And interestingly, in all in every subject which underwent an upsize of stent dimensions because of intravascular imaging, no adverse event was recorded. So this it's very important, and maybe we can discuss this later again. Of course, this study does not come without limitations. This is not an all-comer registry, as Professor Tarantini always says. It's a more-comer registry, meaning that the exclusion criteria, we excluded patients, of course, on the basis of the exclusion criteria per protocol. But if we compare these patients to other all-comer registry, actually this represents less than 7% of the left main PCI patients. Of course, this was not a randomized study, so of course we did perform propensity score weighting, to adjust for potential confounders. But again, it's not a randomized study. The sub-analysis on the extra large vessel platform has some limitations because we have a low number of patients which received this stent platform. Of course, we have a 5-year follow-up planned, and now we plan to extend the follow-up from 2 to 5 years because the 1-year results are encouraging but need to be confirmed at a longer term follow-up. And of course, we did study just one stent, so these results cannot be generalized to other DS platforms. And to conclude, this study is important because it's the largest prospective registry on left main PCI with a dedicated new generation DES, which includes large and extra large vessel platforms. what we can conclude is that at 1 year we have a very good safety and efficacy because the low TLF rate that we saw, and of course, as we were discussing before, prolonged follow-up is important in this subset of patients and is planned in our study to confirm the results. And I'd like to finish with this quote, which is by Robert Byrne, which was commenting our result when Professor Tarantini showed them during the late breaking trial session at EuroPCR 2022. And although we are among interventional cardiologists here, it's important to realize that there is scrutiny in the setting of the left main because the results of the surgeons are very good, and we think that these studies, among other studies in this area, is important because we have to be very careful and thoughtful when we perform left main PCI, and we needed to also to prove that we have good results with the newest generation stents. And with this, I conclude, and thank you for your attention, and I'll pass to Ali for the questions. Thank you.
Great. Thank you very much, Luca. It's a great presentation and summary, and congratulations to you and your center for coordinating and leading this project. Perhaps if we have anybody who has any questions, now would be a good time to ask, but we'll maybe just kickstart with Professor Tarantini, your sort of experience and insight in how this fits in with the rest of the field of left main PCI, particularly because it's a hot topic, it's discussed everywhere and all the time. And how do you see this study fitting into what's already been said?
So first of all, thank you for having me on this discussion. So actually, I think the most important thing in ROLEX is the message, sticking to the comment of Robert Byrne, that there is a great scrutiny around the issue of the left main. That means that the surgeon does a good job. So we need to start from here to understand that when we decide to perform a left main PCI, we need to follow some routes. First of all, we need to be very accurate in the angiography. And when we decide to go for the left main PCI, we need to avoid, especially during the very early experience as interventional cardiologists, to go blinded. That means to go angio-guided PCI. Because actually, as you have seen, adding an imaging, it's like opening the eyes in what you're doing during the procedure. And this is very important because actually, as Luca showed before, you can many times, if you don't need to upsize the selection of the stent, for sure, you will go for more significant post-dilatation to oppose the stent in a better way to the vessel wall, and this is very important in terms of stent thrombosis. In terms also the final result, because we know by the paper of Kerry Means, we know that we have some numbers that are 6, 7, 8, and 9 in Caucasian people that are different from the Asian people that actually are strongly correlated with a good outcome after the stent of the left main. So my takeaways is that, but with the ROLEX trial, we know that following these rules, implanting the latest DS platform, using the iris, using the appropriate size matching between the stent and the vessel is the way to go and to touch the boundary of a target lesion failure of 5%. This is not too bad at all because actually the mortality was very low and the stent thrombosis was about 1%. So the point is that with the left main, the PCI might seem very easy because you don't need to get through a CTO, you don't need to get through a very calcific lesion. So the PCI is very easy at the end, technically. But the point is that you need to be very careful that because with a suboptimal PCI, you may impact the outcome even in a single patient. And this is very important to keep in mind.
Okay, thank you. So questions over to all of you. If anybody has any questions, practical or related to the paper. So Marco, first question. OCT versus IVUS in the context of image guidance for left main.
This is another very important point. So actually, we have to say that we cannot use, one with the other like, being the same thing. Because actually with the IVUS, you're very accurate to analyze also the ostium of the left main. When you use the OCT, sometimes there are papers related to this point. You may miss, you might be less accurate to define the reference vessel because it's very difficult to have a blood-free, segment, etc. So, to my view, the OCT might be very good for the distal bifurcation, defurcation, to highlight, for instance, residual dissection that you don't have enough spatial resolution with the IVUS. And actually, for me, the gold standard remain the IVUS for the left main, especially when you want to use an imaging as a workhorse. When you want to have a workhorse imaging tool, for me, my recommendation is to go to IVUS because you can cover from the ostium to the distality of the left main.
Okay, thank you. Next.
I have a question. Hi, everybody. I'm Rossella from Rimini. We saw in the paper that we can also use FFR for the evaluation of left main disease. In which anatomies or Medina class do you trust your FFR evaluation? First question. And the second question is that even IVUS is recommended now for IVUS for left main PCI. So why only 45% of the patient underwent IVUS? If there is a reason, anatomical, for example, or if there is a reason that you know about that. Thank you.
Okay, Rosella, I think you did a good point. So actually, what about the FFR? Let's start from FFR. There is a disconnection between the theory and the practice related to the FFR. I'll try to explain better what I want to say. If you look at the literature, when you have an angiographic lesion that is less than 50%, let's say intermediate, when you go with FFR, okay, it's very rare to find out a positive result. So actually, at the end of the day, when the lesion is 20–30%, it's very rare to demonstrate that this is a significant left main. But actually, when you have a very tight lesion, again, in the left main, it is more than 70% again, is sometimes might be negative, the FFR in one-fourth of the patients. And actually, the use of FFR, if you ask to me, Giuseppe Tarantini, when you use FFR in the left main, I like to use FFR when I have, on top of the left main lesion, I have multi-vessel disease and multi-lesion disease. Why? Because when you have a lesion in the left main and you have 2 or 3 lesions in LAD or 2 lesions in the circ, you go with the pressure Y, you make a pullback just to isolate the role of the left main compared to the other lesion. And this is very important to be very parsimonious in the final number of stents that you use in this patient. So the answer is that I won't use almost never the physiology to assess and isolate the left main lesion at the level of the ostium of the body, but I will use it when I have a more complex disease to highlight the concept that on top of the left main, I need to treat probably other lesion. So to avoid to go with many stents or other things like that. Related to why the people, 50% of the patient use the IVUS, actually this reflects the real world registry. And actually the penetration in Italy, because you are Italian, you know that the penetration of IVUS in Italy is less than 20%. And actually, if you look at the left main, it's going to be about 40, 30, 40%. You know, I think this is not a good practice. And for sure, the final comments from the chair of the session in the PTR was that on top of 2A indication of the use of IRUS in the left main, with this result, probably we need to upgrade it to be more, strong in indication to say that you had to avoid to go blind when you make a PCI in the left main. Because actually, this is the 5% of the PCI, even less, and actually matter a lot compared to surgery to have a perfect PCI. To have a perfect PCI, unless you are a super expert, I mean 20 years of experience, 500 case load per year as a single operator, I would strongly recommend to go with IRUS.
Great. Okay. We have a question on the chat from Francesco, who's asking about, have you got any sub-analysis planned depending on where the disease is, ostium, shaft, distal, and also with respects to the Medina?
Yeah, now we are, thank you for the question. Yeah, we actually are trying to analyze, and we do have some sub-analysis planned, namely, particularly on bifurcation lesions with use or 1 or 2 stent approach and IRUS imaging. So I cannot go too much into detail about that, but you will hear from us from sub-analysis of this registry, although we have always to keep in mind the fact that, of course, it's not a randomized study. It's not like the EBC main trial. And the percentage of true bifurcation lesions was around 20-25%. So numbers, but sure, we are actually already analyzing this. And particularly we are interested also in looking at predictors of longer term follow-up events. And so it will be important, as I told you before, to extend the follow-up up to 5 years, also to compare these results to those of the main surgery trials. So we do have something planned, but I unfortunately I don't have anything yet to show you and to share with you today.
Okay, thank you. Alessandro, you have a question?
Oh, yes, I have another question. So when you showed the results in terms of bifurcation lesions, you were showing that actually there is a higher prevalence of this setting, and the type of two-stent technique was actually a percentage of the whole population. But it would be interesting to know, in a relative, from a relative perspective, which was the most used technique.
Yeah, it's quite easy. I can answer you like roughly, because I do have the numbers in mind. So if you take around 23% of two-stent techniques, which I think it's the numbers. So DK crash was about 8 to 9%. So, and together with TAP and T-stenting was the most used approach. The rest was culotte, for example, which was less used in our registry. And this is actually different in Italy as compared to other regions. For example, if you look at the registries from the UK, banning all these authors like Hilding Smith and etc. In their registries, culotte, for example, is the most used two-stent approach. But in the ROLEX registry was quite even, between DK crash and T-stenting. Less use of culotte. I think this reflects the practice.
But actually, in the near future, probably we're trying. For the moment, there is an embargo in all these things. But actually, we're trying to merge data sets to analyze, exactly these points. If TAP is going to be superior to DK crash or the things like pooling data on a patient level among the ROLEX and other main randomized trial in this field. And actually, I think that's, I don't know, we have to see when, but actually probably within 1 year we will come up with this data.
Thank you.
Okay, so I think that's just about us over time. So unless there's any other burning questions, I think we'll conclude the session today. Excuse the noise, I'm at the airport. So it just leaves me to say a big thank you to Professor Tarantini, Luca, to all of you for joining, all your questions and discussions. I think we learned a lot of really important things, not only from the study, but the field generally of left main PCI. So I hope you enjoyed that session. We certainly enjoyed it, and we enjoyed hosting you, and look forward to further sessions together.
And look forward to G.
Absolutely, yes.
Rossella,
Yes.
Alessandro, Pierluigi.
Absolutely.
You
We're joining.
you have to, join us just to have a drink all together during G. Okay.
Great. Thank you very much. We will join.
Take care.